evening, everyone. Namaste and greetings from Indian Oncology Foundation and Mice Ideas. It indeed is a very proud privilege on behalf of Mice Ideas and Indian Oncology Foundation to greet everyone and accord a very warm welcome to all those who have found time to register for this masterclass and all the faculty members who have taken time to put up these lectures. We have in excess of 250 registrations for this masterclass, which indeed speaks about the enthusiasm for this particular topic. And the registrations come from far and wide, many countries across the globe. In the next about 2 hours, we do hope to dissect the finer nuances about the disease entity of hepatocellular carcinoma. Friends, about 15 years back, there were not very many options. And this was a disease with a lot of nihilism and pessimism associated with the outcome. Then came the approval for sorafenib for advanced disease. Of course, the loco-regional therapies have continued to dominate along with the surgical efforts at resection and transplantation. But our understanding of the biomarkers and the biology of the disease have led to a point where we have many new drugs in terms of the oral molecules as well as the immune checkpoint inhibitors. We have a very interesting program today. Can we move the slide? So we have a very interesting program today. As I said, Dr. Vijay Agrawal, who's a senior consultant medical oncologist at the Aster CMI Hospitals, Bangalore, will be talking about the immune checkpoint inhibitors in advanced HCC. Next. And the topic of evolution of biomarkers testing and liquid biopsy, which is assumed center stage in today's testing as well as choice of drugs, is being delivered by Dr. Anuradha Chogle from Tata Memorial Hospital. She's the professor and faculty scientist, consultant molecular lab at the TMH Mumbai. Next. The third lecture is by my colleague from Medanta Medicity, Dr. Jyoti Vadva, who's a senior director. And she would be speaking about optimal treatment sequencing following the progression of disease after the first-line therapy. Next. One of the important topics which medical oncologists need to familiarize, and it's a challenge in the clinic. A lot of times we are unable to assess the liver function. Should we use Child-Pugh score? Should we use MELD? There are so many scoring systems. So it continues to be a debate and a whole conundrum. Dr. Neeraj Saraf, who's director of hepatology at Medanta Medicity, will be talking about the assessment of liver function, particularly from the perspective of the understanding of the oncologist. And towards the end, there is a panel discussion, multidisciplinary panel discussion, which I would be moderating. Without further ado, I take this opportunity to invite the first speaker, Dr. Vijay Agrawal, to please take us through the use of immune checkpoint inhibitors.
Thank you very much, Dr. Ved, for giving me this opportunity to talk in this forum today. And also I would like to thank India Oncology Forum as well as Mice Ideas for having me here. So Dr. Ashok Ved has clearly laid down the background as to why we are discussing it, because it's a very, very important topic, specifically in HCC. When you're talking about HCC, I mean, a lot has happened in the past few years than at any point in time in the history of HCC management. Essentially, when we look at the disease, the liver and the occurrence of liver cancer, which is HCC, the tumor microenvironment is quite complex, and there are very key important players that have come out in the recent past that has helped us to develop treatment options for patients with HCC. Some of these key players are your immunomodulators, so your immunosuppressive environments, as well as those drugs that favor the immune response. Your CTLA-4 is an important marker. Your PD-L1 is an important marker which acts on the effector T cells, as opposed to the CTLA-4 which acts on the T regulator cells. Also, we have VEGF inhibitors. So VEGF plays a very, very important role in terms of suppressing the immune system. And so VEGF inhibitors have a decent role to play. And a lot of TKIs act by virtue of VEGF inhibition, as well as tumor-associated macrophages as well. So we all know from practice that TKIs have historically been the mainstay of treatment, but now immunotherapy, particularly PD-L1 inhibitors and CTLA-4 inhibitors, are gaining momentum, and we're here to talk about immunotherapy. When we talk about immune-based therapies for HCC, the PD-L1, PD-1 inhibitors and the CTLA-4 inhibitors currently make up the mainstay of treatment. CAR-T currently is highly experimental and we don't have access to, and similarly are the vaccines. So I think going forward, we'll see a lot of traction with these things, but currently we will limit our discussion to PD-L1, PD-1 inhibitors and CTLA-4 inhibitors. Like I said, I think the first drug that was ever to have shown some benefit in HCC was sorafenib in 2007, and then there was nothing till about 2017. And suddenly in the past 5 years, there's been a flurry of medications that have shown to have some efficacy in HCC, purely because of a better understanding of the pathophysiology of HCC. This was the sorafenib study, which was the SHARP study showing benefit of sorafenib over placebo in 2007. And then this was the REFLECT study showing the benefit of lenvatinib, that it was not inferior to sorafenib in terms of overall survival, but had better response rates and progression-free survival. And hence, sorafenib and lenvatinib has been the mainstay of treatment till fairly recently. So when you talk about immune checkpoint inhibitors, so I'm going to split this into first-line therapy and second-line therapy, and I'm going to concentrate mainly on the checkpoint inhibitors. When looking at first-line, there were two large studies, one using the drug nivolumab, and the other one using the drug atezolizumab, that showed some benefit in first-line therapy, and we'll talk about that. The CheckMate 459 was the nivolumab study, which compared nivolumab to sorafenib. It was a phase 3 study in advanced HCC. And this was still Child-Pugh's A category. And like Dr. Ashraf said, it's very, very important that we understand how we manage our patients based on Child-Pugh's category and not deviate from them, because the outcomes are significantly different. In this trial, nivolumab 240 flat dose was given every 2 weekly, compared to sorafenib 400 milligrams twice a day, daily. And the primary endpoint in this study was overall survival. And the predefined threshold for statistical significance was a hazard ratio of 0.84. Secondary endpoints were progression-free survival, overall response rates. And when we look at the median overall survival and the progression-free survival, there were no difference between the nivolumab arm and the sorafenib arm. So even though numerically it was slightly better, it was not statistically significant in terms of overall survival. So this was actually a negative study. However, there was some quality of life benefit in favor of nivolumab versus sorafenib. But since this was a negative study, nivolumab is currently not approved in first-line therapy for HCC. The other study, which is the I Am Brave study, looked at comparing atezolizumab plus bevacizumab versus sorafenib for first-line treatment for advanced HCC. Again, this was in patients who had Child-Pugh's A and a good ECOG performance status of equal to or less than 1. Patients were randomized between ati-bev versus sorafenib, and the primary endpoints were both overall survival as well as progression-free survival. When we look at the outcome, the primary analysis, the overall survival was actually statistically significantly better in favor of ati-bev combination as opposed to sorafenib. In fact, after the 8.5 months follow-up, the Independent Disease Monitoring Committee stopped the trial and said that the benefit was significant enough for the results to be kind of declared. But this is the data with a median follow-up of over 15.6 months. So median overall survival was 19 months. Now, we've never seen that before, historically, having for any of the patients with HCC, having a median overall survival of 19 months, as opposed to 13 months with sorafenib, the hazard ratio of 0.66. When we look at the progression-free survival, it was just shy of 7 months in favor of ati-bev compared to 4 months with sorafenib, again, a hazard ratio of 0.65. And we start looking at an overall survival, 18 months, 52% of the patients in the ati-bev arm are still alive. Response rates almost tripled in the ati-bev combination as opposed to sorafenib, with 30% in the ati-bev versus 11% in sorafenib. And the duration of response was about 18 months in the Atibev group versus 15 months in the sorafenib group. So all in all, a good outcome. In fact, there was a significant number of complete responses as well. So about 8% complete response in the Atibev group, as opposed to less than 1% in the sorafenib group. Quality of life was also better in those patients who received Atibev compared to sorafenib. So when you're looking at time to deterioration, the hazard ratio was 0.63, and the median time to deterioration in terms of months was 11.2 in Atibev versus 3.6 in sorafenib. So all in all, I think this was a very, very good study, well-conducted study with good outcomes in benefit of our patients. Toxicity was similar for all grades across both the age groups, so both the arms. But when you look at grade 3-4 toxicity, there was significantly less in the Atibev group compared to sorafenib group. So some of the key warnings in terms of when we're using Atibev, I think one of the things that I would like to highlight is that all these patients need to undergo endoscopy to ensure that there's no imminent bleeding varices, and that they should not be having active hepatitis B and C, which may flare up if patients are put on Atibev combination. A lot of studies, a lot of work is going on in terms of other combinations of immune checkpoint inhibitors with other systemic agents, particularly in combinations with TKIs, with pembrolizumab, ati, cabozantinib, as well as with CTLA-4 inhibitors. So we have durva, tremelimumab, nivo, ipilimumab combinations. So a lot of work is going on that, and I think going further, we will wait for these trial data to be more mature and give us more options for our patients for first-line treatment for HCC. So we know that single agent probably does not have the same effect as combinations do, like we've seen with the lack of effect with nivolumab, but a good outcome with Atibev combination. So I think only time will tell whether whether these combinations will be useful. So we're looking at NCC, and the preferred regime currently is Atibev combination, but in Child-Pugh A only. So the question is, what next in terms of second line? So if you've got Atibev combinations, I think the other TKIs will take second line. But if you've given only TKIs in terms of sorafenib and lenvatinib, what options do we have for second line? So we'll look at a little bit of data on the use of nivolumab, pembrolizumab, and nivo-ipi combinations. Various early studies in second line therapy, both with nivolumab and pembrolizumab, showed some decent activity with a response rate of about 15%, give or take, and a median overall survival of about a year and a bit. So based on that, further large studies were carried on. So one of the most important study was the Pembro study, looking at its benefit in the Keynote 240 study. So those patients who had progressed on sorafenib but remained Child-Pugh A were included in the study, and the patients were randomized between Pembro versus placebo and best supportive care, and a primary endpoint was progression-free survival and overall survival. And as we can see from this study, that there was statistically significant improvement in the overall survival as well as the progression-free survival. However, in the overall survival, because there were pre-specified statistical significance of p-value of 0.17, and the overall survival did not meet that, I think we cannot take that as face value for overall survival. But clearly, in terms of progression-free survival, there was statistically significant improvement in Pembro arm versus the placebo arm. When look at the nivolumab studies, the Checkmate 040. So this was quite a complicated trial, which had about 5 cohorts, and this was cohort 1 and 2. And this was a phase 1 study looking at dose escalation, and then a phase 2 component was a dose expansion study where patients who had progressed on sorafenib or refused sorafenib were included in the study. The dose escalation was to find the dose, and when the dose was identified as 3 milligram per kilo, then went on the dose expansion study. And we can see that overall, whether the patient received sorafenib or did not receive sorafenib, or had HPV or HCV infected, and they were all evaluated separately, had approximate response rates of about 20%, give or take. A median overall survival in the uninfected progressors were about 13 months, others were not reached. And the median progression-free survival was about 4 months, or 4 to 5 months, so to speak. Overall survival, however, was 15 months, in all of the patients put together. However, based on that, based on this, initially FDA gave approval for nivolumab in second-line study, however, withdrew its approval in second line after the failure of nivolumab study in the first-line setting. So Checkmate 459, once that failed, FDA withdrew its approval for nivolumab in second-line setting. So currently, nivolumab alone does not have approval neither in the first-line setting nor in the second-line setting. But Pembro does have. This was one of the other cohorts. Cohort 4 looked at nivolumab plus ipilimumab combination in those patients who progress on sorafenib but continues to remain of Child-Pugh's 5 and 6. Now, so Child-Pugh's A5 and A6 and a good performance status. This study looked at 3 different dosing combinations: Nivo 1 EP3, Nivo 3 EP1, and Nivo 3 EP1 6 weekly. And clearly the benefit was seen in terms of overall survival. The biggest benefit was seen in those patients who had Nivo 1 milligram per kilo body weight and ipilimumab 3 milligram per kilo body weight, which had a median overall survival of 22 months. So that was a fantastic outcome, but we all know that it is extremely difficult in practice to deliver ipilimumab 3 milligram. But based on this, FDA did approve Nivo EP combination. But the Nivo EP combination that we tend to use in our practice and other tumor types are nivolumab 3 milligram per kilo and ipilimumab 1 milligram, which had a median overall survival of 12.5 months. But the FDA gave approval for Nivo 1 and EP3, and we know that that is quite difficult to deliver in our practice. Nevertheless, the outcomes of 22 months overall survival was fantastic. So this was the 3 arms, and when we look at the side effects, we can see that the Nivo 1 EP3, which has the FDA approval, any side effect was 94%, and grade 3-4 toxicity was in excess of 50%. When we're looking at the other 2 groups, the grade 3-4 toxicity was about 30%. So the vast majority of the patients who get EP1, Nivo 1 and EP3 are likely to develop some form of grade 3 or 4 toxicity. So I think practically it would become difficult for us to deliver this regime. Child-Pugh's, I know we're going to discuss a lot about Child-Pugh's later on, but all the studies I've so far discussed and shown essentially were for Child-Pugh's A. There was one cohort in the Checkmate 040 study which looked at giving nivolumab single agent for patients with Child-Pugh's B7 patients, and essentially this cohort, so B7 B8 cohorts, and this did show some good outcomes in this group of patients, with a median overall survival of about 7.6 months in previously treated, and in 9.8 months in those patients who were previously not treated with sorafenib, and treatment-related adverse events were not higher in this group of patients as opposed to Child-Pugh's A. So there is some data that one can try nivolumab single agent if the patient is of Child-Pugh's B7 or B8. When looking at retrospective study, a very, very small patient numbers, but however, it gives us a similar picture. Clearly, those patients who've got a Child-Pugh's A, which is the extreme right column, have a response rate of 20%, which is similar to what we get in the real life study. And when you're looking at treatment-related adverse events, we realized that they were not that much more compared to those patients with Child-Pugh's B or A, as per the Checkmate 04 study. So one could argue that you could give nivolumab in this group of patients. So when you're looking at a second-line therapy, when looking at immunotherapy, which is in the center, Nivo plus Ipi for Child-Pugh's A only. But let us not forget that this has Nivo 1 milligram per kilo body weight and Ipi 3 milligram per kilo body weight. And Pembro, again, Child-Pugh's A only. So these 2 are reasonable drugs to consider in second-line therapy. In Child-Pugh's B, one can consider nivolumab if someone wants to give immunotherapy in second line in a Child-Pugh's B. So to summarize, I think Ati-Bev should be the first-line immunotherapy combination, followed by Nivo, Ipi, or Pembro as second line, unless the patient is Child-Pugh's B, where you could consider nivolumab single agent. Now, coming to the last couple of slides, when you're looking at expanding the role of immune checkpoint inhibitors, I think going further, we will be looking at IO combinations with a host of other treatment options, combining with anti-angiogenesis that we're already doing with Ati-Bev, but various other combinations in terms of vaccination, adoptive cell therapies, other tyrosine kinase inhibitors, and local ablations such as teratase and so forth. So I think we'll have to watch the space for that. Immunotherapy of HCC in 2021, I think we've come a long way in the past 5 years in such a short span. And when we start looking at BCLC, BCLC category towards the right in terms of when we're looking at advanced HCC, the available therapies currently are anti-BEV combination, Nivo, EP combination, nivolumab and pembrolizumab. Others are in late stage of trials, and there are various other combinations under investigation. So we've got a lot of excitement coming forward in terms of treatment for HCC, and I think we just have to watch the space, and hopefully our patients will continue to benefit more going further. Thank you very much.
Thank you, Dr. Vijay, for that wonderful exposition, summarizing the topic so very well and a very clear message, and stacking the various immune checkpoint inhibitors according to the usage in the clinic. Thanks, Vijay. We would be taking the question answers in the panel discussion, and stay on. You are one of the panelists out there. Let's move on, and I have the privilege of inviting Dr. Anuradha to speak on the evolution of biomarker testing and liquid biopsy for HCC. And we agree that a lot of things are now revolving around biomarker testing, and hopefully we would be moving from the real biopsies to liquid biopsies, making the life of our patients much easier, and then maybe track the tumors over a period of time. Thank you so much, Dr. Anuradha. Over to you.
Dr. Anuradha, please unmute yourself.
Okay, yeah, I think so. Hello, everyone. I think I'm audible, right?
Yeah,
yes,
very well.
Yeah. Thank you, Dr. Ashok Bed. Actually, if you ask me, I'm at Ali Park enjoying my weekend, but I did accept the invitation, and thank you for this opportunity. So what exactly with the Dr. Vijay Agarwal's talk, like it was really, we have timeline, we have march past from just AFP or some conventional chemotherapy to immune check inhibitors, and also with the targeted therapies. So what exactly malignant tumor, it has a high morbidity and mortality. And currently the screening of HCC relies on serum alpha fetoprotein. Can you next slide, please? Oh, I will have to do that for the next. Okay. So currently the screening of HCC relies on serum AFP, ultrasound in combination, imaging, and tumor biopsy has really limited the diagnostic potential and sensitivity. Now coming with the diverse oncogenic pathways, which is underpinned by varied driver genes, you can be induced by different etiological factors, like including virus infection, toxin exposures, or metabolic disorders. The patient may display varied genetic profiles and may respond differently to the treatment involving inhibition of targeted pathways. So when in the solid tumor, if you are going to do by FFP, you really miss many times the mutations because some large deletions or some masked copy number variations you never get to see. But on the NGS, yes, you can. And with the liquid biopsy, definitely it has improved a lot, because the liquid biopsy is supposed to be the true representative of the FFP sample or the tumor burden. So you can look for DNA RNA mutations, copy number variations, chromatic structural changes, aberrant expression of non-coding RNAs, and epigenetic modifications. These are the main biomarkers which are considered in today's application of precision medicine. Can I have the next slide, please? So already Dr. Vijay has explained the different clinical trials which are going on, either as a targeted therapy or as immune check inhibitors, where we have finished with long-going clinical trials. So I won't be going into the details of this. Can I have next slide? So similarly, this current clinical trials which are investigating the combination therapy of targeted agents and the immune check inhibitors for and they are really doing wonders. As you have seen in the slides, their overall survival rate has also increased. Next slide, please. So this is the signaling pathways which are affected by the etiological factors. As you must have seen, the HBV, HCV infection, alcohol consumption, aflatoxin exposure, NFLD, and metabolic disorders, they trigger the HCC by manipulating the diverse signaling pathways, and how these different mutations are involved in genetic profiling and with the different stage advances as well. Next slide. Uh, so, the interaction between the genetic predisposition and there are several environmental factors and hepatocellular carcinoma occurrence. So this is, as you can see over here in this, there is under the Mendelian disease, you have the germline H1F1A mutation, glycogen storage disease, and if you do the screening, it may land up with the hepatocellular adenoma. Whereas Wilson disease, you come across hemochromatosis, trisomia, several Mendelian diseases like alpha-1 and antitrypsin or deficiency. They all come under the Mendelian disease. However, this Wilson disease may in future go into the hepatocellular carcinoma as well. As you can see, there are several polymorphisms are involved, like hepatitis C, metabolic syndrome, alcohol. As alcohol generated, or you can say effect of alcohol. You can see many factors are viral factors are involved, like hepatitis B, aflatoxin, and so on. So under the once the cirrhosis, you may come across some factors, genes like MDM2, IL-10, TNF alpha, epithelial growth factor, MICA, and DEPDCS. If the patient goes under cirrhosis, you also can do the screening where you can look for the GTS1M1 and glutathione STT1. Again, for the chemo prevention, you need to look for the TP53, MDM2, IL-10, TNF alpha, and STAT4. So these are the insertional mutagenesis, and they are all involved in the hepatocellular carcinoma, and you get definitely a genomic imprint of viral and environmental factor which induces the hepatocellular carcinoma. Next slide, please. So the genomic landscape and the driver pathways which are involved in liver carcinogenesis, like for example in the telomere, Wnt-B-catenin pathway, epigenetic modifier, these are the several pathways which are involved. And you can see in the red, which represent the activation mutation of oncogenes, while the blue color represents the inactivating mutations of tumor suppressors, which denotes and the asterisk denotes the gene which is recurrently targeted by the HBV integration. So there are different pathways which are involved, under which we get to see the different type of mutation, and under the cell cycle gene, again you get to see the IRF2, MDM2, P53, CDKN2A, and retinoblastoma gene ETF. So there are several pathways which are involved, and these all the genes which we can include in the panel for the NGS testing as well. The main important pathways, the AKT and mTOR and MAP kinase pathways. So where you can see under the AKT, mTOR and MAP kinase pathways, you get to see the RAS-MAP pathway, then you get to see the PI3K, AKT involved, which are the down signaling pathways for the MAP kinase pathway. Under the oxidative stress, yes, you get to see several other NFE2, L2, and these are the detoxification program. And these marker or biomarker also can be included in the NGS panel. One of the important epigenetic modifier is the ARID1, where you get to see the ARID1 and ARID2, which are the crucial components of the switch sucrose non-fermentable, that is SW1 and SNF1 complex. And these adenosine triphosphate dependent complex participates in the gene transcription stimulation or the suppression through the chromosomal remodeling. And this inactivated mutation of ARID1A or ARID2 frequently are present in many HCC patients and are clinically associated with the cancer development. So though ARID2 is most prevalent as compared to ARID1, but still we get to see some 14.3% of the added one in the targeted HCC population. So these are the various pathways which are involved. And can I have a next slide? Yeah. So these are the mechanism of malignant transformation in hepatocellular carcinoma as you go from march past from cirrhosis to low-grade dysplastic nodule, high-grade dysplastic nodule, and early hepatocellular carcinoma, in which the third promoter mutation is highly involved. And you also get to see the TP53, CTNNB1, ARID1, ARID2, MLL2, ATM, AXIN1, RPSK3, and KEAP1 biomarker. So there is a whole lot of profile which has been involved recently in the hepatocellular carcinoma diagnosis, or you can say for the in the NGS panel. Are they really important in doing so? Can I have the next slide, please? So based on that, you can see the molecular classification of HCC. You get to see the proliferation class as well as you get to see the non-proliferation class. So under the proliferation class, you get to see the various progenitors like EpCAM, S2, under the cell lineage features, and the hepatocyte like late TGF beta and S1. There are also prognostic gene signatures which are involved, DNA somatic alterations are involved, and down the line, you get to see the signaling pathway activation, as I mentioned earlier, the RAS, MAP, K pathway, MET, and AKT and mTOR pathway. Under the epigenetic, I already mentioned about the miRNA involvement as well. Under the non-proliferation class, like they are hepatocyte-like, you get to see the S3 cluster B, Wnt CTNNB pathway, and you get to see the also CTNNB1 mutation and the DNA amplification chromosome 7 mutation. So the major classes and proliferation, non-proliferation are depicted based on the mRNA expression profiling. So for here also, you with the mRNA expression profiling, there either you can do the NGS panel or you can go with the microarray expression. So the additional molecular features affecting DNA structure pathway deregulation and epigenetics are getting overlapped in the mRNA expression. Can I have the next slide? Yeah. So here you can see already Dr. Vijay has mentioned that there are so many targeted therapies which are involved as the first line or regorafenib as the second line when you have these against these markers like VEGFR and 1, 2, 3 and PDGFR or VEGFR3, FGFR1 to 4, PDGFR alpha, KIT, c-KIT and RET mutation as well. And the cabozantinib like VEGFR or MET and AXL, and nivolumab against the PD-1 and PD-L1 monoclonal antibody. Next slide, please. So the pathways and molecular which are inhibited by drugs, as you have seen, like they are involved in the VEGFR2 angiogenesis or can make pathways, RAS-RAF pathways, and finally they go into the apoptosis. Similarly, you can get to see in another tumor cell. These are the vascular endothelial cell. And again, you get to see the tumor cell involvement, where again, these several inhibited targeted therapies are involved. Next slide, please. So these are the candidate drivers as targets for the therapies in hepatocellular carcinoma. So again, I won't go into the detail. You can see if there is a DNA amplification for FGFR9, CC and D1, VEGF8, TERT, MYC and FAN, you get to see the different altered pathways and also the drugs which are available. So there are several, apart from DNA amplification, you get to see the gene mutations and also an overexpression like MET, IGF2, which are also under the signaling pathways of AKT and mTOR pathway. Can I have the next slide? So whether are we really you have to depend on the FFP samples? I will say no, because nowadays the liquid biopsy is becoming the most convenient tool to do the ctDNA NGS panel. And this is how it has improved over a period of time, that liquid biopsy has become convenient, where we can look upon for the circulating tumor cell, you can look upon the exosome, extracellular vesicle, cell-free DNA, circulating tumor DNA, miRNA, and these can be very well used for the early diagnosis and the prognosis. So either you can use the samples, blood, serum, plasma, urine, CSF, saliva, anything. They have become very much convenient tools for the NGS panel. So what exactly is the liquid biopsy? Can I have the next slide, please? So these are the, as you can see over here, they are the true representatives, the cells which are the, what exactly are the ctDNA? They are the small fragmented DNA having a base pair size ranging from 125 base pair to 160 base pair size, which are present in the circulating free DNA. So many a times the question is how different the ctDNA is from the cfDNA. I will say that the ctDNA are the part of cfDNA in when there is a carcinoma or when there is a cancer as such. So the so the liquid biopsy, you can, as I mentioned earlier, you can detect point mutation, epigenetic modifications, microRNA, and several whole lot of spectrum can be looked upon in that. Can I have next slide? So this is the schematic workflow. If either you can, if you want to look for single gene mutation, you can use a droplet-based digital PCR, or you can do a broad spectrum NGS panel where where the DNA is extracted. You get to have the DNA fragmentation, and you can make the libraries, you can sequence and analyze. So these methods profile targets by fracturing the DNA molecules into small sequences, and then you can have the proceeds into further into massive parallel sequencing. Can I have the next slide? So high frequency genetic markers of hepatocellular carcinoma and the key pathways. I have already explained about this, how this various down signaling cancer cell survival, how the which are the mutations which are involved, like under the CTNNB, you get to see the APC, GSK3, axin, beta catenin, and so on and so forth. And again, under the proliferation tumor cell survival, invasion, and metastasis, you get to see the under the cell cycle arrest, again CDK4/6, which is a very important biomarker, and also the P16 biomarker, which is very important in the hepatocellular carcinoma to differentiate in the stages. Can I have the next slide, please? Yeah. So this already it has become a repeat, so I won't go into the detail. Can I have the next slide? So what is the, when you compare the of the CTC or DNA or the ctDNA and the tumor DNA? So CTC DNA is, that is a circulating tumor cell, and the CTC is, and ctDNA is a circulating tumor DNA. Circulating tumor cells, from that you extract the DNA. When you talk about the CTC, there is a, what is the advantage? You get a greater allele frequency, you get to see the new mutation, but however, you have to have the low, you get a low coverage depth, and they are with the less abundant. Again, if you are using ctDNA, you have the advantages, you get to have abundant analysis material, and it has a very high sensitivity. However, there is a lower allele frequency, which are dying cell sources. So you have to have a greater coverage, like at least 10,000x coverage when you are looking for the ctDNA. Tumor DNA, again FFP, that is gold standard. Non-enough analysis material unable to reflect the tumor heterogeneity, risk, and discomfort. Of course, you get to, these are the disadvantage when you're looking for the tumor DNA. Next slide, please. So already I've explained about the component and molecular analysis, circulating tumor DNA, extracellular vesicles, and the CTC, that is the circulating tumor cells. So I won't go again much into the detail, but here it depicts how, what are the components which can be extracted from just the blood sample. Next slide. So this is the whole landscape and level of evidence of liquid biopsy studies across different clinical implications, that you can do the ctDNA methylation, which is very important because the methylation has supposed to be can be used for the screening, and it can be a very important biomarker in the early detection, and it has been it is being regularly used in the phase 3 biomarker, which studies are available for the HCC LOE2. Now, what is LOE2? Is the entities with the level of evidence as defined in the lower panel. So these are the different biomarkers which can be used under the landscape of the hepatocellular carcinoma. Can I have the next slide, please? So liquid biopsy in the clinical management, is it really becoming popular? Yes, you can use it for the methylation profiling from plasma DNA. You can discriminate with the early stage HCC from patient at risk. Clinical trials testing the performance of these biomarkers in cirrhotic patient against the standard survival surveillance with the ultrasound alpha fetoprotein, which are ongoing. So, and also the early studies suggest that the composite biomarkers of mutation in circulating tumor DNA and tumor markers such as AFP and are able to identify the HCC. That is the best carboxyprothrombin biomarker. Next slide, please. So what are the potential future applications of liquid biopsy? Prognostication by molecular analysis of circulating tumor cell, ctDNA, and or extracellular vesicles, which has a predicting risk of recurrence or detection of MRD after resection. For example, by detecting the detection of CTC and or ctDNA, these markers improve the clinical trial design for testing adjuvant therapies. Also, there is a prediction of response to systemic therapies. For example, you can do the molecular analysis of extracellular vesicles and or mutations from the circulating tumor disk. Also, you can do the monitoring treatment response, tumor burden, and identification of emerging clones of resistance to systemic therapies, for example, by mutation analysis from the circulating tumor DNA. Can I have the next slide? So these are the therapy options, which I won't go into detail again, because already with the previous talk, it has been explained. So what is the current status? Can I have the next slide? So what is the current status of ctDNA in precision oncology? It has a transformative, ctDNA is a transformative biomarker aimed at precision monitoring of HCC patient during the overall course of the treatment. The choice of ctDNA markers has not yet reached to the agreement, however, because detection technology is time consuming and expensive, and we need to do it with the ctDNA very meticulously. Further exploring is very much essential when applied to the patient with HCC. So still we can't bring the last slide. Can I have the last slide, please? Okay. Thank you so much. This was my last slide. However, I would like to mention that though the ctDNA is being used as a research, but not into the clinic at present. Thank you so much.
Thank you, Dr. Anuradha. That was a wonderful roundup of the liquid biopsy vis-a-vis hepatocellular carcinoma, and I'm sure the postgraduates on the program would have got a comprehensive idea about the liquid biopsy. So,
it was sorry.
Sorry, Doc. So I take this. Hello.
Yeah.
Thank you, Dr. Anuradha, once again, and that was wonderful. And I'm sure, as I said, the postgraduates on the programs would have immensely benefited out of your lecture. Thanks once again. And we move on to the next presentation, which is optimal treatment sequencing following progression of disease, to be delivered by Dr. Jyoti Wadhwa. Over to you, Dr. Jyoti.
Good evening, everyone. Thank you, sir. The topic of my presentation is, as Dr. Ved mentioned, optimal treatment sequencing following progression of disease. So just give me a moment. So ever since the approval of sorafenib as per the BASIS SHARP and the Asia Pacific trial Since 2007, the path of HCC has been strewn with many milestone developments. So there have been advances not only in terms of first-line treatment, but also in second-line treatment of advanced stage hepatocellular carcinoma. And the lower half of the slide mentions the attempts. Some did fail, say Brivaneb and Exitinib and Everolimus. They could not stand the test of time. However, we have various molecules which are now US FDA and approved, and they are part of standard guidelines by various authorities. And we have more than one options, even in second-line treatment of patients with HCC who have failed the current standard treatment, which may be either sorafenib, lenvatinib, or bevacizumab. So this slide mentions the approved therapies of HCC as of today. So you would notice that sorafenib, lenvatinib, and the combination therapy of atezo-bev is approved as first-line treatment of HCC. In second-line treatment, we have multiple and many more agents which have got the approval, namely regorafenib, cabozantinib, ramucirumab, and immune checkpoint inhibitors, namely nivolumab, the combination of nivo-ipi, and pembrolizumab. So I'll be talking briefly about each of these drugs and the trials which got them their respective approvals. So cabozantinib got the approval based on the trials called Celestial trial. It established the efficacy of cabozantinib in HCC with child-PUG A category. Nivolumab got the approval basis Checkmate 40. Pembrolizumab had two trials, 240 and 224. Ramucirumab got the approval based on the REACH-2 trial, and regorafenib, based on the trial Resource, got its approval as second-line treatment in HCC. So before we start talking about these treatments, let's see where they act, how do they actually act. So we are all aware that bevacizumab and ramucirumab basically are anti-angiogenic agents, which act by blocking the VEGF receptors. On the other hand, cabozantinib is a multi-kinase inhibitor. It acts on multiple targets. Similarly, lenvatinib and regorafenib, they act in more than one ways and they block more than one pathway. Thereby, they have enhanced potency and efficacy in treatment of these patients. Immune checkpoint inhibitors, we all know, they are anti-PD-1 or PD-L1. So let's start with regorafenib. So it's a broader spectrum when compared to sorafenib. It's much more potent and it acts on all these receptors which are listed here. The trial Resource studied the role of second-line regorafenib in comparison to placebo in patients who had disease progression on sorafenib when used in first line. So the patients had to have good performance status, had to belong to BCLC stage B or C, and had to belong to child-PUG category A. So regorafenib was used in the standard dose of 160 milligrams orally daily, 3 weeks on, 1 week off. The other arm being the placebo arm. Best supportive care was a constant component in both the arms. The treatment was continued until disease progression or unacceptable toxicity. Overall survival was the primary endpoint. So we noticed that regorafenib performed better than the placebo. The median OS was 10.6 months compared to 7.8 months with the placebo. And the progression-free survival was also better, 3.1 months compared to 1.5 months with hazard ratio of 0.46. The time from sorafenib to death was studied, and the use of regorafenib did extend this time from the start of first-line treatment in form of sorafenib to death. So regorafenib did extend the survival in all the patients and also in both the Asian and non-Asian subsets. The treatment-related adverse events were as predicted for regorafenib, namely the hand-foot syndrome, hypertension, these being the class effects of this molecule. Diarrhea was also problematic in some. However, almost none of the patients had grade 4 toxicity with regorafenib. Coming to the second molecule, that is cabozantinib, and we now have this impressive molecule approved by DCGI and available to us in India for use as second-line treatment of HCC. So Celestial is the trial which established the efficacy of cabozantinib in patients who had previously been treated with up to 2 lines of prior treatment, including sorafenib. Again, the trial included patients in good performance status, child-hook class A. Cabozantinib dose was 60 milligrams. However, treatment dose reductions to 40 milligrams and then subsequently to 20 milligrams were used in significant number of patients. The other arm was placebo, and the treatment was continued until disease progression or unacceptable toxicity. Again, the primary endpoint was overall survival. Cabozantinib did perform very well here. The median OS was 10.2 months compared to 8 months in the placebo arm, the hazard ratio being 0.76. The median PFS was also superior, 5.2 months with cabozantinib. The Celestial trial also analyzed the outcome in patients for whom sorafenib was the only prior used systemic therapy. And if the patients had responded to sorafenib, meaning thereby that they had been on sorafenib prior to getting onto cabozantinib for say 6 months or more, you would notice here that the median overall survival was in fact the best, 12.3 months versus 9.2 months with the placebo. And similarly, the PFS was also a little bit better in this arm of 6 months or more when compared to those who had failed sorafenib very early on, and they had been on prior sorafenib for just less than 3 months. The responses, cabozantinib was able to induce some partial responses. Most of the response could be classified as stable disease in this trial. The treatment-related side effects, cabozantinib, grade 3 side effects, the significant proportion of patients did have diarrhea, again, hand-foot syndrome. Fatigue was also a common side effect, and hypertension, as expected, was also seen. And it was mainly the diarrhea and the hand-foot syndrome which often resulted in dose reductions to 40 and sometimes to 20 milligrams a day of cabozantinib. So based on the Celestial trial, cabozantinib, wherein the cabozantinib by targeting multiple pathways, namely the MET, the AXL, and the VEGF receptors, resulted in higher OS and PFS when compared to placebo, got its approval as second-line treatment, and it has found its place as category 1 recommendation in the most recent NCCN guidelines. The third molecule is ramucirumab. We know that this is anti-VEGF receptor 2 monoclonal antibody. So this was, REACH2 was a randomized double-blind multi-center phase 3 trial, which included patients who had progressed on sorafenib, and the patients had serum AFP levels of 400 or greater, BCLC stage B or C, and again, child-hook class A, good performance status, and they had to have failed sorafenib before going on to receive ramucirumab. So ramucirumab used in standard dose of 8 milligrams per kilogram every 2 weeks, and treatment continued till progression. Again, primary endpoint was overall survival. The median OS was 8.5 months with ramucirumab versus 7.3 months in the placebo arm. Not a great separation there. The median PFS was 2.8 months versus 1.6 months, but the hazard ratio here was 0.45. So the pooled overall survival, the comparison was made in patients who had serum AFP level of 400 or more. So herein, when the separation was done this way, ramucirumab was able to lead to a median OS of 8.1 months compared to 5 months in the placebo arm, hazard ratio being 0.69. Again, the side effects of ramucirumab, as expected, the VEGF receptors, as they are known to lead to sometimes fatigue is a common side effect. Blood pressure needs monitoring. There could be peripheral edema, some dyspepsia, and some patients did have fever as well. So these are the three trials that I have already talked about, which have included targeting of VEGF pathway, namely RESOURCE with regorafenib, Celestial with cabozantinib, and REACH2 with ramucirumab. And all these three agents were found to be working better when compared to placebo in second-line treatment of HCC, and all these three got their approvals. Now, coming to another class of drugs called immune checkpoint inhibitors, and Dr. Vijay has already dealt with this topic in detail. I'll just briefly mention here the Keynote 240 trial. The initial trial had failed to reach the pre-specified level of statistical significance, both for OS and PFS in the primary analysis, when the median follow-up was up to 13 months. The updated analysis with additional 18 months follow-up is represented here in this slide. And you would notice here that pembrolizumab led to median OS of 13.9 months versus 10.6 months in the placebo arm. And the median PFS was 3.3 months and compared to 2.8 months in the placebo arm. And herein, it seemed to attain a significance. And there was another study, Keynote 224, of pembrolizumab monotherapy for patients with advanced HCC who had no prior therapy. And this again established the efficacy of pembrolizumab. So based on these trials, pembrolizumab has a definite place in treatment of HCC after they have progressed on sorafenib. The other combination is the IO, that is nivolumab and ipilimumab, the Checkmate 040, and Dr. Vijay did mention about this trial. This was used, and 3 different dosing schemes of the nivo and ipi were used in these patients. And the best performer was nivolumab 1 milligram per kg, with ipi in the dose of 3 milligram per kg Q3 weekly. However, as he rightly mentioned, this is more toxic dose of ipi. And however, in this trial, that seemed to lead to the best median OS in to the tune of 22 months. However, in our practice, we are most comfortable using the second level of dosing, which led to a median OS of 12.5 months. But based on this Checkmate 040, this IO combination is approved for the treatment, second-line treatment of patients with HCC. So we have seen that over past decade, the landscape of treatment of HCC has been evolving. We have 3 agents which have their approval in the first-line treatment. Sorafenib still stays there and quite useful still for a subset of our patients. The other options being lenvatinib, and the best efficacy has been documented with the combination of atezo-bev. However, in the second line also, we have more than one options to choose from. So sometimes actually it may become confusing as to how to choose the second best option. And there's a lot of progress still ongoing. These are some of the phase 3 trials which are still studying some more agents, the combination of IO with TKIs. Again, the combination of different immune checkpoint inhibitors is also under study. And this is how the current NCCN guidelines look like. So if you focus on the subsequent line treatment on disease progression, we have category 1 recommendation for both regorafenib cabozantinib, and ramucirumab. We also have the option of the IO-IO combination and nivo and pembrolizumab as single agents as well. The ESMO guidelines also reproduce the same, what I showed. They are very similar to the NCCN guidelines. Again, the same agents are approved and they are placed as second-line treatment, as I already mentioned. But I made this slide to just facilitate or ease the process of choosing and sequencing different drugs for second-line treatment. So if somebody has failed sorafenib, but the sorafenib tolerability was not an issue, regorafenib could be a wise choice. Cabozantinib is in particular very useful in those who have failed more than one prior regimes, and in particular have been sorafenib intolerant. Ramucirumab has a definite place if the serum AFP is 400 or greater. And if we are looking for durable responses, then one of the two immune checkpoint inhibitors could be a wise choice. So sequencing must take into account the exposure to all the classes of drugs which have already been used, what has been the duration of their efficacy, what has been their tolerability, and accordingly one should choose. So suppose the patient has received the so-called best or better first-line treatment with atezo-bev, then the second-line option could very well be lenvatinib or regorafenib, and the other options could then be used subsequently as third-line or beyond. However, if the patient has received lenvatinib in the front line, then in the second line, one could offer again regorafenib or cabozantinib, and atezo-bev, the immune checkpoint inhibitors, could now be used and could be offered. So this is, I think, my last slide. Yes, and I would stop my presentation here. Thank you.
Thank you, Dr. Jyoti, for telling us the right sequence, dwelling on the various options, and very elegantly laying out the various scenarios in terms of the prior exposure, followed by the choice of the drug based on the rational use of these drugs. I think we have a couple of minutes, and there are a few questions in the question box. We probably could take those. And there is a question from Dr. Asif Nisar. Do you see an evolving role of liquid biopsy for HCC screening in high-risk population, given the overall dismal prognosis of HCC? Dr. Anuradha, this question is for screening in a certain population of high-risk population. Dr. Anuradha, are you there? If you could take this question. Okay, we'll come back to that. And there is another.
I'm there.
Yeah.
Yeah,
Okay,
I'm there.
please.
Can you repeat the question? Hello? Can you repeat the question, please?
That is there a evolving role for liquid biopsy in the screening of high-risk HCC? High-risk population, not HCC, but high-risk population, given the fact that there is a dismal prognosis of HCC.
Yes, you can do the DNA methylation, which is nowadays used for the screening for the high-risk population. DNA methylation.
Okay. So there is another question from Dr. Nin. Did any study check the quality of life in those checkpoint inhibitors and placebos? So Dr. Jyoti, Dr. Vijay, anyone could take this.
I can take that. Sorry. This is Dr. Vijay, Dr. Ashok. So
Sure,
both
please.
the first line studies, that is your Checkmate 459, looked at quality of life versus sorafenib, and showed better quality of life in those patients who received nivolumab versus sorafenib, as well as the most important study that we spoke about, the IM-BRAVE, looked at atezo-bev combination. They also looked at time to deterioration as a marker of quality of life, and showed that the time to deterioration in those patients who received ati-bev was about 11 months as opposed to 3.6 in the sorafenib arm. So both the first-line studies did look at quality of life, and both of them were in favor of IO, whether it's nivolumab or atezolizumab.
Dr. Vijay, I have a question here. When we are talking of the VEGF usage, and most of these drugs are VEGF driven, be the orals versus the BEV. How about the risk of bleeding? And these are patients who somewhere or the other do have a hepatic dysfunction. And maybe I can see Dr. Neeraj also on the program. Dr. Neeraj could also sort of offer his comment on that.
So one is obviously we worry about bleeding from esophageal varices, and all patients on some form of TKI, particularly atezolizumab, we tend to do pre-treatment endoscopy to look at esophageal varices, and if they are present, we get them treated before we start treatment, and then we do a 3-monthly follow-up after that on a regular basis. Portal vein thrombosis and anticoagulation does become a little bit of a problem, but clearly not an absolute contraindication for VEGF inhibitors. And again, we stick to Child-Pugh B7, or if you're giving atezolizumab, we stick to Child-Pugh A. We do not give it if there was significant clotting dysfunction.
Thank you, Vijay. Dr. Neeraj?
Yeah, I agree with Dr. Vijay. I think especially for atezolizumab, we do, although we have very limited experience with it right now, but we do variceal screen for these patients and we eradicate the varices if they are varices. So there's a definite, risk with with atezolizumab.
Thank
one,
you. Thank you, Dr.
Comment, Dr. Ved, one comment.
Please
so
go ahead.
These patients have chronic liver disease and they often have thrombocytopenia as well. So is there some recommendation regarding the lowest cutoff for platelet count before we choose this atezo-bev combination because of bevacizumab in it? So say 50,000 or greater, or
so Dr. Vijay, would you have a comment on that?
So certainly the protocols that I use in my practice has a 75,000 cutoff. So we extrapolated from other tumor types. I don't think so there's specific indication in HCC as such, but anything less than 75, we worry about it. More than 75 is where we are comfortable.
So, Dr. Neeraj, would you have a guidance to the medical oncologist on that point?
I'm not aware of, but I'm not, honestly, I wouldn't worry too much about the platelets because, cirrhotics, even with 20,000 or 30,000, they would rarely have a spontaneous bleed. So it's not just the quantity of platelets, it's the quality also. And so, I don't know, but personally, I don't think it should be a big issue unless they're like very low, maybe less than 20,000. But I'm not aware of any guidelines or any, any specific point at which it should not be given.
Very well. I think Dr. Neeraj, stay on, and I have the privilege of inviting you to deliver the next talk. And this is on assessment of liver function. Over to you, Dr. Neeraj.
I'll just share my screen. Okay, can you see my slides? Hello?
Yes, sir.
Yeah, okay. So first of all, I'd like to thank Dr. Ved for inviting me to this meeting. And I'm probably the only hepatologist here, although I would consider Dr. Jyoti Wadhwa maybe a 50% hepatologist.
I love that comment, Dr. Neeraj. Thank you.
You lived for so many years with a leading
25 years, going to complete.
So I'm sure some hepatology has rubbed off.
Right.
Okay, so I'll be speaking on assessing liver function in management of HCC. And I think HCC is a very unique tumor that way. It's probably one of the only tumors in which the function of the organ is, equally important or equally detrimental in prognosticating as compared to the tumor itself. And in a lot of times it's the liver function which, takes away the patient rather than the HCC. I can't seem to move my slide. Okay, yeah. So I'll be talking on some of the tools and models to assess liver function and liver disease severity in context of managing HCC. I'll talk of interpretation of the CTP score. I was asked to do that. And I'll talk on application of these liver function assessment in various modalities of HCC management, like liver resection, liver transplant, ablative or locoregional therapy, and systemic therapy, which we've all been talking about. So this is the classical standard slide of the BCLC staging for liver cancer. And as you can see that, uh, like I just said, the stage of the tumor is important in deciding what treatment can be given, whether it's ablation, resection, transplant, or systemic therapy. But equally important is the liver function. And you can see that in each stage, the liver function is important, in deciding the management. So you could have a small HCC, but a bad liver, and that would preclude a particular treatment. You could have a larger HCC, but a good liver, and that would enable certain treatments. So how do we assess this liver function in patients with HCC? And I'll talk of that in the next a few odd minutes. So these are the various tools or models available for assessing liver function. And the most common and probably the most widely used and most applicable score is the child Trucott Puck score. Then we have the MELD score. There's something called the albumin bilirubin grade. I'll talk of that. I think very basic and important is, again, to look at the presence of clinically significant portal hypertension. We were just talking of, varices in atezo-bev. And so looking at varices or sometimes at the hepatic venous pressure gradient can tell us about the liver function and, how to go about treating HCC in that particular patient. And then we have some other modalities like CT volumetry. And I'll talk a little bit on indocyanine green clearance, which is important to assess function specifically in patients undergoing surgical resection. So we have two types of liver functions assessment tools. They are static and dynamic. So most of the time we are using these static tests, which involve bilirubin, the liver enzymes, albumin, INR, and then we have various models like the CTP or the MELD, where we fit in these static tests. And then we have dynamic tests, and I'll talk of one of them, which is most widely used, which is the ICG clearance. So let's first talk of static tests. Now, we all know the CTP score, the child Turcotte Puck score, and this is most widely used to really assess the severity of liver disease, and not just for HCC, but I think for in day-to-day clinical practice and even for deciding when to transplant a patient. So just a little bit of history. So basically this score was devised in 1964 by Child and Turcotte, and who used this score to select patients for a portal decompression surgery. And then subsequently it was modified in 1973 by Pug, and three classes were formed: CTPA, good function; B, moderately impaired function; and CTPC, advanced hepatic dysfunction. So B and C class are usually considered as decompensated, and no elective surgery is generally advised in class C. So almost all HCC therapeutic trials exclude patients with CTP more than 7. And I think when Dr. Jyoti was showing her slides, you could see all studies had either only child A or B up to 7 only. So nothing beyond 7. So what does CTP score include what are the parameters. So you have bilirubin, you have albumin, you have ascites, and you have encephalopathy. And first it was, initial days, there was nutritional status, and then which was replaced by prothrombin time when it was modified by PUG. So as of today, we have bilirubin, albumin, ascites, encephalopathy, and prothrombin time. And depending on the various values, you give scores from 1 to 3, and then we have uh, uh, 5. If you have 5 to 6 points, it's class A. If it's 7 to 9 points, it's class B. And if you have 10 to 15 points, is class C. So if we talk of HCC, I think most of the times we're talking of class A and selected class B, and class C is rarely indication for any form of HCC therapy except for liver transplantation. Now, one thing which also I want to highlight, and I'll talk of that a little later, is when we talk of, see, class A is easy. I think most trials use class A. It's where class B, where it is important to decide whether you should give systemic therapy or any other local regional therapy to that patient. And I think it has to be individualized. So for me, if you have class B because of low albumin, that is not as bad as having class B because of high bilirubin. So, within class B also, I would say that bilirubin carries a more worse prognosis as compared to having a lower albumin or a very mild ascites. So what do we mean when we say child's A, B, C? So they have implications on prognosis. So if we look very, basically child C has a more than 30% 1-year mortality, child B has a 20% 5-year mortality, and child A has a 5-year or less than 10% mortality. Now, these are again some prognostic ability charts just to highlight the importance of CTP score in prognostication. So this is a 3-month mortality based on CTP score. So 3-month mortality is much higher in child C, 11 to 40% as compared to child A, which is just 4.3%. And similarly, survival in patients with CTP score, longer survival, and you can see that blue, which is child A, is significantly higher as compared to child C in 1 and in 2-year survival. So child A has clearly the best survival, child C has the worst survival. And this is again a recent meta-analysis of 118 studies, which again looked at the prognostic value of the CTP score. And again, you can see that the 1-year and 2-year survival of child A is significantly better as compared to child B, and which is the child C is clearly worse 1-year and 2-year mortality. Now, but CTP score is, so it's easy to calculate. It's a bedside score, and I think it's extremely useful, and it gives a fairly good idea of liver disease severity. Now, there are some cons to the CTP score as well. Uh, I think the biggest criticism of CTP score is that it is subjective. So you have especially 2 parameters, ascites and encephalopathy, which are not really quantifiable. So it's subjective. It could vary between, 2 clinicians or historically. And I think that's one of the major drawbacks of CTP score. And that's where MELT score scores over CTP. And I'll talk of the ALBI grade, which again scores over the CTP. The other, the modality which I want to sort of highlight is the presence of clinically significant portal hypertension. So like we were talking, presence of clinically significant portal hypertension actually means a HVPG more than 10. And it has been shown that there is higher risk of any complication, any major event if you have clinically significant portal hypertension of HVPG more than 10, and even a higher risk if you have a HVPG more than 12. So obviously we're not going around measuring HVPG in all patients. So a simple way would be to look at varices, and varices usually form when the HVPG is more than 10. So if a patient has varices, that means he has clinically significant portal hypertension, and that plays a definite role when you're deciding for surgical resection. So patients who have lower HVPG or clinically significant portal hypertension are usually compensated, and patients who have bleed or higher HVPG or clinically significant portal hypertension generally tend to decompensate. So again, this is to highlight that we need to differentiate when we treat HCC between compensated and decompensated patients. And decompensated usually have higher HVPG, they would have ascites, they would have jaundice, they would have encephalopathy, and that's again various stages of decompensation, and all the complications I mentioned are late stages of decompensation. So for most HCC, these are the patients who are best candidates, except, like I said, barring liver transplantation, where you can, obviously transplant a decompensated patient. But resection, loco-regional therapies, and systemic therapy, I think most of the times we are choosing compensated patients. Another recently developed tool which has some new data is the ALB grade, which is the albumin bilirubin grade, and this is a formula based calculation involving the bilirubin and albumin, and you can based on the formula you can have ALB grade 1, 2, and 3, where you have values of 2.6, more than 2.6 to 1.39, and more than 1.39. Now, this honestly, we really don't use this in clinical practice a lot, but there is data to suggest that it's probably better than the CTP score, and it's easy to use. Again, it's something which you can do on the bedside, just involves two parameters, bilirubin and albumin, and takes away the subjectivity of the CTP score. The other, the benefit of the ALB grade is that it differentiates even between the CTP-A. So this is actually a graph showing that even, these are all patients of CTP-A, that you can actually differentiate the survival even within the same group based on the ALB score. And again, like I said, it eliminates the need for subjective variables such as ascites and encephalopathy. So this is something which there's a lot of recent data on, but at least I haven't really used it in clinical practice. Another model which is used commonly to assess liver function, but not again very commonly used in HCC, is the MELD score. This is the most widely used score to decide about candidacy for transplant. So this again involves three parameters: the creatinine, bilirubin, and the INR. And this predicts short-term pre-liver transplant mortality. And so this is the 3-month survival based on the MELD score. So if you have a MELD score, the lowest score is 6. So if you have a MELD score of 6, you have a 94% 3-year survival. And if you have a MELD score of 40, the MELD is capped at 40. So if you have a MELD score of 40, the 3-month survival is just 6%. Now, the reason I think MELD score is not really used in any HCC trial, because it's a short-term prognostic score, just prognosticating for 3 months. And I think another reason for not using it is probably it heavily weighs in patients who have renal dysfunction, which is important for transplant, but may not be important for other forms of therapy for HCC, like systemic therapy. Probably a little higher creatinine probably doesn't matter. So that's why MELD score is not really a part of HCC trials or clinical use. Now, just very quickly, how do we apply these models? So in various forms of treatment, so for liver resection, we generally would take a patient with child's A and maybe early B. Portal hypertension is very important when we take a patient for resection. HVPG more than 10 or presence of varices is usually a contraindication, especially for major resection. You could do minor resections, but definitely not major. Another very important test is the ICG retention test on how much ICG can be cleared. And MELD is also often used for resection, and we would not resect patients with a MELD score of more than 9. So just a minute on ICG clearance. This is a dynamic assessment of liver function, and ICG is an inert water-soluble, fluorescent tricarbosine with a protein binding close to 95%. So the more ICG you can clear, the better the liver is. And this is a very commonly used, a test to decide candidacy for resection. It predicts post-resection liver dysfunction. It's a non-invasive marker of portal hypertension and non-invasive marker of esophageal varices itself. So this is a very famous algorithm, which is the Makuchi criteria for deciding on resection based on the ICG. So if you have ascites, which is not controllable, then obviously no resection. If you have ascites, which is if there's no ascites or controllable, then you look at the bilirubin. If it's less than 1.5, limited resection, less than 2, enucleation. If bilirubin is more than 2, then no hepatectomy is advised. And if the bilirubin is normal, then you can do the ICG R15. So how much ICG is cleared in 15 minutes? So generally 10 to 15% is taken as a good value. So if a patient can clear about 10%, clear 90% and retain only 10% in about 15 minutes, that's a good hepatic reserve and would do well after resection. This is just again a new paper showing the value of ICG clearance, and they actually put the cutoff at 5.6%, saying that if you retain ICG at 15 minutes more than 5.6%, then you have chances of liver dysfunction. So coming to the applicability of these scores in systemic therapy, I think like Dr. Jyoti showed, if you look at all the approved drugs, all of them have actually been done only in class A, class A, class A. I don't think there's any drug. Some trials have used early child's B7. So for systemic therapy, I think we are totally, as of now, depending on the CTP score. And I think that fairly tells us on the disease severity and whether a patient can be given these systemic therapies. There's very limited data on use of any of these drugs in CTP-B. I think except for sorafenib, there is some data on sorafenib, and there's absolutely no data or no use, or they're contraindicated in child C. But unfortunately, that is the problem, that in real life, a lot of patients you see are actually child B and child C, and unfortunately we're not able to, at least as of today, use most of these drugs. So similarly for loco-regional therapy, most guidelines suggest, if you look at child spoke A and selected B7, so most European guidelines and the ASLD recommend that loco-regional therapies be done in child's A patients and selected child's B patients. So again, CTP score is basically used in deciding candidacy for loco-regional therapy as well, just like systemic therapy. Liver transplant is the only modality where HCC is the determining feature. So if you have a large HCC or HCC with vascular invasion, then these are not candidates for transplant. Liver function is usually not a contraindication. Yes, performance status can be a contraindication, and CTP score and MELD scores are commonly used to decide the disease severity for liver transplantation. So to summarize, assessing liver disease severity is an integral part of staging and managing HCC. CTP score is the mainstay. I think most modalities of treatment and most studies in systemic therapy use CTP score. It is useful for surgery, for loco-regional therapy, and for systemic therapy. ICG clearance is of specific value for resection, and it adds to the CTP score. And I think something as simple as looking at varices and seeing whether a patient has compensated cirrhosis or presence of clinically significant portal hypertension is useful in deciding liver reserve and the safety of these various treatment modalities. Thank you.
Thank you, Dr. Neeraj. And that was wonderful for us medical oncologists on a day-to-day basis, the understanding about the
You will be sharing the screen.
I think there is something.
Sir, you need to mute one device.
So something has gone wrong with the connection. I had to log in from another device.
Sir, you need to mute one device.
Yeah. Am I visible now?
Yes, sir.
Am I visible now?
Yes, sir.
Yes, yes,
Am I audible? Am I visible?
yes. Both.
Yes, sir.
Rajesh?
Yes, sir. You
Yes,
are
sir.
visible and audible both. So in the meantime,
Am I visible? Am I audible?
yes, sir.
Okay. I think let's get going. My apologies. There is something wrong which happened on the other device. So I think having gone through the presentations about the therapeutics and the assessment of the liver function. Thank you, Dr. Neeraj, for that wonderful presentation and telling us about two diseases in one. Hepatocellular a lot of times presents with a background liver dysfunction and how to manage both at the same time. We are joined in the panel discussion by Dr. Mohan Das from Tata Memorial Center, Kolkata. He doesn't need any introduction. He's one of the senior most medical oncologists. He's one of the senior most GI oncologists in the country today, and also joined by Dr. Ashwati Matthew from the Radiation Department, Apollo Proton Cancer Center, Chennai. And I also invite the other presenters to join the panel out here. Let's get going. Can somebody share the slides from your end, because I'm unable to share from this device. So we would next slide, Neerav. We would go through some of the controversies in the management of hepatocellular carcinoma and look at the surgical resection, controversies in the intra-arterial treatments, and first line and second line therapies. Next slide, please. Before we go to the surgical resection, my first question would be to Dr. Mohan Das. Dr. Mohan Das, you have practiced long years, and we understand that the annual incidence almost mirrors the mortality and the incidence. They almost mirror each other. The 1 year survival beyond for those who are on medical therapies is very dismal. Over the years, are you seeing any shift in the presentation? Is there a stage migration? That is part one of the question. And part two is that with the newer therapies, TKIs, the immune checkpoint inhibitors, are we changing the natural history of the disease?
Coming to a real change,
If you follow the Globocan and the cancer incidence in 5 countries before that, you don't really see much of a change. Our incidence rates is about 5 per lakh population, and mortality is also near about that. So not much, but I think at individual levels, yes, the hepatologists have become more proactive. They are screening patients, so they are detecting cancers early. We are seeing more liver resections happening. And we are also seeing a lot of liver transplantation happening. So both these things are curative treatments. The rest of it is not curative. So there would be an increase, but not in national scale. But I think at institutional levels, yes, there would be an increase in patients getting cured.
Thank you so much. And I would come back to you on the question or the issue about the surgical resection and the outcome. Before I come back to you, Dr. Neeraj, you and Dr. Mohan Das both work with in a multidisciplinary setting. Neeraj, you work with the liver transplant team, and then all of us understand that Medanta has a large transplant program. You work with the GI surgery, you work with the interventional radiologists, and then they are quite active. And also you work with the medical oncologists. Now, and you see all these patients post-resection, post-transplants. Where do you place the role of surgical resection, and what are the limits of surgical resection?
So I think, especially maybe there's some bias. I think at our center, we're definitely seeing very little surgical resection. So I think the reason for that is probably a very strong, there could be a bias because of, very strong intervention radiology and a very strong transplant program. And I think the other reason is probably the candidates for surgical resection are very few. So like I said, most patients who come to us have, advanced liver disease as well. They are Child's B or Child C, where obviously surgical resection cannot be done. So I think surgical resection, at least at our center, is, probably declining. As far as limits, I think, again, patients with early Child's B or with clinically significant portal hypertension, sometimes, maybe minor resections can be done, but certainly not major. Another technique which our surgeons use is, when the remnant is low, you can embolize the portal vein and, cause hypertrophy of the opposite lobe and then resect. So I think some limits are being pushed in terms of how much volume you can leave with the patient. So I think portal vein embolization is something which helps us, go beyond these limits.
Thank you, Dr. Neeraj. And Dr. Mohan Das, I come back to you on the same subject. And
yes,
you also...
I kind of agree with Neeraj. The number of patients undergoing transplant in India is probably more than the number of patients having a liver resection. And the main reason is that because these patients have very advanced liver disease. I'm not talking of cancer, just the liver disease is very advanced. And when you estimate the residual liver function, the FLR, the likelihood that the patient will decompensate after the resection, then keeping all those things in mind, the number of patients who are fit for undergoing resection are, relatively few.
Thank you so much. Please stay on. I have the next slide out here. Nirav, can we move the slide? Next. So this is a slide about the surgical resection versus TACE. Dr. Mohandas, what would be your message that wherever we can resect, we should resect and not succumb to the local original therapies?
Right.
So how would you place it? But also there is a bias about the patient selection.
So, I mean, doing a liver resection in patients with cirrhosis is not a simple thing that can be done in all practices. So you also need to have the appropriate team. Otherwise, I've seen liver resections in the late 1980s and 1990s where mortality used to be very high, or the patient would decompensate after the surgery. So all those, keeping those things in mind, it has to be done in centers that are regularly doing the procedure and are able to accurately determine the status of the patients.
Thank you so much. Let's move on. Nirav, can we move to the next slide?
See, like for example, an MR of the liver to look for smaller, tiny lesions that may be missed on a CT scan, a bone scan, and a chest CT are also important because you don't want the patient to have a recurrence in the lung or in the bone after the resection has been carried out.
So since you have talked about the recurrence, Dr. Vijay, we need your insight into, is there a role for any adjuvant therapy post-surgical resection?
So currently, there is absolutely no role for adjuvant therapy because, like you just showed the slide, the STORM trial looked at giving sorafenib in adjuvant patients, and that had absolutely no difference in terms of overall survival. Having said that, we are aware that there are a lot of trials, particularly IO combinations, and we ourselves are participating in the EMERALD-2 trial, which is looking at durvalumab and BEV combination in the adjuvant setting. So I think we just currently have to watch the space to see of the many trials that are going on in adjuvant setting, whether any of them are positive. But as of now, in the clinical situation, we are not giving any adjuvant therapy.
So on the same subject, Dr. Anuradha, are you there?
Yes,
So thank you so much. So once loco-regional therapy, maybe in terms of the surgical resection has been done, there was an earlier question about the screening with liquid biopsies. How about the post-surgical resection? Would there be a strong role for liquid biopsies? Because we ultimately would rely on the serum markers and some sort of imaging. A liquid biopsy would be much easier.
yes.
Do you see a role evolving for liquid biopsies?
Yes, definitely. There is a role for the liquid biopsy, unless it is done very meticulously, because we need to extract those ctDNA fragments very carefully, because it's just the small DNA fragments which has a short life or a half-life of about 2 hours. So how it is done is very important. Definitely, liquid biopsy is a true representative for monitoring the disease as well as looking for the various molecular profiling biomarkers. If you go to take the CTC, that is circulating tumor cells, it becomes little bit tricky because 1 in 10 ml of blood, you get to see that the tumor cell, which is very difficult to take it further for the molecular profile. But yes, liquid biopsy ctDNA has a definite role.
And how frequently, according to you, would this be required? Would it be something in about 3 months' time or 6 months' time?
See, a post-resection, I think you can keep a gap of 3 months, and then thereafter, if you want to monitor the disease, you can do it after every 3 months, because it's a very partial, non-invasive procedures. You can have the blood, and the patients most of them are adult patients. So you can definitely draw the blood. It's not a difficult task.
But just for the sake of the discussion and putting the things in perspective, because there are a lot of postgraduates also on the program.
Yeah.
Is there a standardization for HCC? And is this a clinical tool, or the message would be that still is an experimental work or a work in progress?
Yeah, how the liquid biopsy is well established in lung cancer, there is no such mature data which we can see in the hepatocellular carcinoma. However, having said that, we can use it in the research, and there are, as you can see, the various biomarkers are involved, which we can taken into consideration as a profiling tool. But of course, the FFP sample still remains a gold standard.
Thank you so much. Nirav, next slide. Can we move the slide? Now, let's look at some of the intra-arterial treatments and the subject of radiation out here. Next slide. Now, Neeraj, back to you. And since you work with the interventional radiologist very closely, a very quick comment about is the drug-eluting beads DEB taste something like a standard of care, or a bland taste could still also be considered in these patients?
So I think as far as I know, DEB taste is not available now. I think we were doing it a few years ago. But I think these, at least I don't think we are doing it anymore in the last 3-4 years, probably because of availability issue.
Right. Dr. Mohandas, what do you do at your center?
They have these, the new beads, I forget the commercial name. There is I think they're called blue beads.
Mm-hmm.
Yeah.
Okay.
That's what is used.
Okay. And Nirav, can we move the slide? Next slide, please. Next slide, please.
But there have been several randomized trials in the past that have compared bland versus chemo.
Yes, that's the slide I have put up. Yeah. There have been trials where the data is sort of, waxing and waning. Some evidence for and also against the drug-eluting beads. Next slide, please. Can we move, Nirav? Next. So the question about the Y99, we know that the US FDA originally gave approval for the metastasis of colorectal cancer. And then, of course, being a regionally directed therapy. So, Dr. Matthews, we would ask your comment on this. What about the internal radiation therapy with Y99 comparing with other loco-regional therapies? And also for early disease, your comment about the use of radiation like an SBRT, or maybe you work in a proton center. So the third question would be part of the question. Third part of the question would be any role for emerging role or an established role for proton therapy.
Thank you, sir. Thank you for this opportunity. And so regarding Y90, I mean, I deal mainly with external beam radiation. And of course, this is the domain of nuclear medicine physician. But the effectiveness of Y90 is, it is definitely gaining ground. More and more people are preferring Y90 as compared to TACE because of the local ablative effect that it offers. So the main effect of Y90 is the radio embolization rather than the embolization and the chemotherapy that TACE will offer. So because of that local ablative effect, it offers very good, it offers higher local control than with TACE, because TACE is notorious to have almost an 80% local recurrence in the treated areas, especially in the previous series, maybe not so much with the newer techniques, but the old Lovett et al. Study does show a very high rate of local recurrence. So TARE seems to improve over that. And also the definite advantage that whereas TACE is contraindicated in patients with main portal vein thrombi, TARE does not seem to be, because it is mainly the radio embolic effect that is the embolic effect that it, the radio ablative effect that it offers. So the second part of the question was about SBRT. So in early stage disease, definitely SBRT does have a role, because again, it has been shown to locally ablate small tumors very well. In fact, Japanese series show, again, very high local control rates, upwards of 90% at 2 years and 3 years. Of course, it does not alter the natural history of HCC, in which, of course, the patient will be prone to developing disease outside of the treated area. But it does show very high local control rates for early stage disease. And even in the situation of downstaging and bridging to transplant, which again can be considered for early stage disease, there is again emerging evidence that it offers effective downstaging, which so pathological complete response rates in the transplanted in the explant liver of around 20 to 25%, which is definitely encouraging, sir. The third part of the question, sir, proton, actually, so there has been a recent study which has come out, which is a small randomized control trial from Korea, comparing, which is a head-on comparison of proton therapy and RFA for early stage HCCs. And it is a non-inferiority design, and it has actually shown that proton therapy is non-inferior to RFA for locally ablating early stage disease. So I think this is the first randomized trial which has actually compared any of the radiation modalities, especially the external radiation modalities, directly with the other liver-directed therapies like RFA, microwave, or TACE. So we had a paucity of data in this aspect of external beam radiation techniques. And I think this small trial, but it is definitely encouraging and supporting the feeling that we all had all along, that indeed, radiation, whether external or internal, does have a good local ablative effect.
Thank you so much for that very cogent, very clear, crisp answer to all those questions. Nirav, can we move the slide? So move on. Next. I think these points all have been discussed, and next we'll move on next. Now, something we didn't have as a presentation for some particular reason about the first line therapy in HCC. We did talk about the immune checkpoint inhibitors, the second line treatment. Now, in the first line treatment, let me bring the two medical oncologists back into discussion again. So today we have a clear approval for the two TKIs, and I have a question to Dr. Vijay. Is sorafenib irrelevant today? And I have a question for Dr. Mohandas. Is lenvatinib the new standard of care? So let's go one by one. Dr. Vijay, you could take up the is sorafenib irrelevant today?
So not really. I think sorafenib has been a standard of care for a very long time, in better part of more than a decade now. And we know how to use sorafenib very well. We know its toxicity, we know its dosing, and essentially that will probably continue to remain the standard of care for some time to come. It is very, very cost effective. And I think let us not forget that there are most of our patients are not necessarily Child-Pugh A. A lot of them are Child-Pugh B, and the only drug apart from nivolumab that we can give in Child-Pugh B continues to be only sorafenib. So I think sorafenib is here to stay. I agree that there are other alternatives that can also be used in the first line setting. I don't think sorafenib is going anywhere in the immediate future.
So the corollary to that question, Dr. Mohandas, that is lenvatinib the new standard of care? And based on the non-inferiority trial, but the progression-free survival and the need for the next treatment in the trial was favoring lenvatinib. Your comments, sir?
Yeah, so now that we have a whole lot of somebody is talking.
Hello.
Could we request to mute yourself, please?
Yeah. So coming back to the question, lenvatinib as the first line standard of care. I think sorafenib and lenvatinib are equally good in terms of improving the overall survival. There is a feeling among the practitioners in India that lenvatinib is a little less toxic as compared to sorafenib, although we have really not gathered proper unbiased data to show this, but there has been a trend. In the beginning, lenvatinib was expensive. Now we have a large number of generics and have made it very affordable. So from a cost point of view, there is very little to choose between sorafenib and lenvatinib. From the side effect point of view, I generally prefer to use lenvatinib. Otherwise, I think from an effectiveness point of view, they are similar.
Excellent, sir. Thank you so much for that comment. And of course, the availability of both the drugs is equally good, and the cost factors have also. And I would tend to agree with you that the overall feeling is that lenvatinib is a little less toxic and easier to tolerate.
Yeah, but there is one thing I want to add, that if you look at all the studies, starting from SHARP, and now the comparator in the IO trial, you find that the arm that took sorafenib, actually the survival has improved over a period of time. In each of these studies, the median survival has got pushed up further. And although, of course, you can't do a cross-trial comparison, but I think this is because of better case selection and better management of toxicity, which we have learned over a period of time. So now, it is much easier to use sorafenib than it was, say, 10 years ago.
Thank you, sir.
So could it also be due to the fact that there are now more and more second line and third line options than compared to 2008, when sorafenib was the only approved therapy?
Yeah, that's of course one of the things in the OS, and second line treatments after progression is something that, but generally it is only patients who preserve themselves well after the progression who are given second line treatment. So case selection is happening.
Sure.
I think we are very, very quickly coming to the timelines. There are two questions. One in the question box, which is anonymous. The question is, are we justified in using atezo-bev upfront in non-viral NASH-related CLD? Atezo-bev, non-viral NASH-related CLD with metastatic HCC with child POC-B, based on limited number of patients in the IM-BRAVE 150 trial. Dr. Vijay, you had presented this data.
Yeah, I wouldn't worry so much about the NASH part, but child POC-B is an absolute no for atezo-bev. We don't have any data that atezo-bev can be used in a child POC-B.
Thank you so much. And there is a question, a larger question to everyone. Everyone could comment on that. We are seeing patients post-transplant, and they are on immunosuppression. Dr. Neeraj, we need your comment also. And use of immune checkpoint inhibitors. Is it totally a no-go, or could the immune suppression be lowered, and depending upon, is there a window of opportunity of using the newer agents in the post-transplant HCCs?
Yeah, so I think as far as nivolumab is definitely contraindicated because it causes severe rejection, and we have never used that. The other, I think we have been using sorafenib for the last many years in post-transplant recurrence. Now we have started using lenvatinib in post-transplant recurrence as well. So I think these two drugs have definitely been used. Nivolumab is definitely a no. I have some limited experience with regorafenib in patients who progressed on sorafenib, but then very limited. So, but mostly sorafenib and lenvatinib.
So any comments from the other panelists?
Sir, I must say that we've actually seen a patient, he came for local therapy for adrenal met. So definitely it's not something very common, but we have seen patients who have been put on immuno. So this patient was receiving pembro, if I'm not wrong, and who did not have any, graft rejection to speak of. Wow. So patients do, we have seen that situation. Of course, select patients, and we have actually treated this patient with an SBRT for the adrenal met, and he survived at least 6 or 9 months post that as well. So we did not see any graft rejection in that particular patient. And he was on immune suppression as well as immunotherapy. Sir.
That's amazing, because there is a black box warning for the immune checkpoint inhibitors. Nirav, can we move this slide and let me see if we still have time for. Let me go back, to the dosing of lenvatinib, since we are discussing the first line therapies. And A, the dosing, and B, the Child-Pugh score, and where would you not go to the TKIs, which is an absolute contraindication, and what's the segment of patients where the systemic therapy would fit in? So there are two parts to the question. One, the dosing, and number two, the right score, which would be applicable. Dr. Vijay, Dr. Mohandas, both of you could comment on that.
So as far as the B is concerned, Child-Pugh B, I mean, B is a very broad group, and somebody who has 6 is quite different from someone who has a score of 9. So my practice is to talk to the patient, because if you really see the benefit, it is just about 2 months in survival, nothing more than that. So you need to make them understand that there is a possibility that you may live for 2 more months. There is a possibility that the liver can deteriorate, and then if they are okay, some of them are desperate and want it at all costs. If I don't do it, they'll go to some other oncologist in the city and take it from there. So after much explanation and making them understand, I do start them on sorafenib or lenvatinib. My usual practice is to give lenvatinib at 10 milligrams for those who are above 60 kilos of weight. So that's what I do. Otherwise, sorafenib, most of my patients I have found are unable to tolerate the full dose. So I usually start for such patients who are already, beyond A at half the dose and escalate if they are tolerated.
So, Dr. Vijay, you also escalate or you de-escalate? And your thoughts about the Child-Pugh and the dosing of lenvatinib.
So the dosing, I agree. I stick to the dosing as recommended, 10 milligrams for above 60 kilos and 8 for below 60 kilos for lenvatinib. Sorafenib, I never start with 800. I always struggle with 800. So I start with 400 and then escalate up to 600. I rarely go to 800 now, unless it's an international patient. So most of our domestic patients is 400 to 600 in terms of sorafenib. Coming to Child-Pughs, I give lenvatinib currently only for Child-Pughs A. If they go on to B and they still want treatment, I stick to sorafenib, and that's my practice, and that's what I do.
Thank you so much. I think I'm looking at the timeline also. It's already past 8 o'clock. We have exceeded our timeline. I take this opportunity to thank everyone, particularly the participants from across the globe who have logged in, first and foremost, and secondly, all the faculty members who took out time and gave their insights, their valuable opinions, and wonderful talks, a great educational feast. And I'm sure this would add a tremendous educational value to all of us and help modulate and shape our practices as well. My sincere thanks to our knowledge partner, Eisai, for who have sponsored the meeting this evening. And we also, in the same series, announced the next meeting for November and December. They would be on 24th and 3rd of December would be lung cancer. That's a much bigger topic. So we have split that into 2 sessions. I thank Mr. Malik at Indian Oncology Foundation and Dr. Rajesh. Now I call him doctor because it takes 4.5 years to be a doctor, and he's in the field for much more beyond that. And also Nirav and Kalpesh for the wonderful support at the Mice Ideas. With that, ladies and gentlemen, we come to the close of this session. And if there are any comments or questions, still we open it for the same over the next about a minute or so.
So there is a question in the question box. Are we justified in using atezolizumab upfront in non-viral NASH-related CLD with MSCC with child B based on limited number of patients in Embryo 150 trial?
This has been addressed, Rajesh. This has been already, this has been answered. This has been
I
answered.
missed it in between.
Okay. Thank you so much, ladies and gentlemen. Stay safe, take care, and see you 24th November once again. Thanks, everyone. Good night.
Thanks, everyone. Have a good
Thanks,
weekend.
everyone.
Thank you, Dr. Shadwell. Thank you very much.
Thank you.
Thank you.
Thank you, everybody.
Thank you. Bye-bye.